So in 1997, a computer scientist spent, I think, $20 on public photo records and successfully mailed the sitting governor of Massachusetts his own highly classified medical diagnoses,
Yep.
just to prove a point.
Yeah, and the crazy part is she didn't hack into a secure government server to do it. She just used basic math and some, supposed anonymous data that the state had legally just given away.
Which is wild. So welcome to today's deep dive. We are looking at a massive stack of sources detailing the history, the hidden legal mechanics, and honestly, the spectacular real-world failures of AI and patient privacy.
Right, and it's a huge topic.
It really is. Our mission for today is exploring the line you never cross in healthcare. And we designed this deep dive specifically for you, the curious learner. So whether you are a nursing student prepping to step onto the floor for the first time, a seasoned healthcare professional trying to protect your license, or, just a patient who wants to know who actually has legal access to your medical secrets.
Yeah, and to set the stage for you today, I've actually updated my backdrop. We've got the classic dusty medical records archive, those endless aisles of manila folders. But as you look closely, the paper is sort of dissolving into these glowing digital data streams.
Oh, I love that.
Thanks. Because that intersection, right, where the physical chart meets the digital network, that is where this entire story really begins.
Absolutely. Because when you hear the acronym IAPA, your eyes probably glaze over a bit. It sounds like the most dry, bureaucratic, paper-pushing nonsense imaginable.
It really does.
But the reality in these sources is wild. This law is at the dead center of massive celebrity tabloid scandals, multi-million-dollar international hacks, and intense debates about who actually owns your body's information. Okay, let's unpack this.
Right.
Because before we can talk about how to protect health data, we have to look at what the law actually covers.
Right.
And based on the sources, what the public thinks IP is and what it legally is are just two entirely different universes.
Yeah, they really are. And to understand that disconnect, you have to look at the legislative origin.
Yeah.
Because people think HIPAA was written as this, grand, sweeping privacy manifesto.
Which it totally wasn't.
Not at all. It was passed in 1996 under President Bill Clinton, sponsored by Senators Kennedy and Kassebaum, and its original purpose had almost nothing to do with privacy.
Yeah, the first P in HIPAA doesn't even stand for privacy. It stands for portability.
Exactly. Title I of the law was just designed to help workers keep their health insurance when they lost or changed jobs.
Right.
Then you have Title II, which was really about reducing healthcare fraud and simplifying billing. Because in 1996, hospitals were just drowning in paper. So to fix that, the government wanted to force the healthcare industry to standardize and digitize electronic transactions.
They were trying to drag the medical system into the computer age, basically.
Yeah.
But in doing so, they created this massive vulnerability because before 1996, your medical privacy was mostly protected by physics, right?
That's a great way to put it, yeah.
Your chart lived in a physical manila folder in a physical cabinet in one specific town. It was incredibly hard to steal thousands of records because you'd literally need a moving truck to do it.
Exactly. But once you mandate that every hospital and clinic in America put sensitive patient records onto computers and send them over networks, you massively increase the risk of exposure. So privacy was essentially a necessary patch like an afterthought to protect the new digitization process.
And a heavily delayed patch, according to the timeline. Congress missed its own deadline to pass the privacy legislation. So the Department of Health and Human Services, HHS, they eventually had to step in and write the privacy rule administratively.
Right, they had to do it themselves.
Yeah, and wasn't even finalized until 2000 under Secretary Donna Shalala. And they didn't even start enforcing it until 2003.
Right. And that structural history explains why the law has such a frustratingly narrow scope today. Because IPA only covers what's called protected health information, or PHI, and it only applies when that information is held by a covered entity or their business associates.
Let's define those categories, because that's the trap most people fall into, right?
Oh, constantly.
So a covered entity is a hospital, a doctor's office, or a health insurance plan. And a business associate is a company they hire to handle that data, like a medical billing company or a cloud storage vendor.
Right.
Meaning a massive amount of modern health data is simply ignored by the law. Your Fitbit,
yeah,
not covered. Your 23andMe genetic testing, not covered. The HR files at your corporate job or those health support groups on Facebook,
none of it.
None of that falls under IPAT, even though the data is incredibly sensitive. Is IPAT essentially just a bouncer for a very specific VIP room of data? while letting anyone else in the club trade our health secrets.
What's fascinating here is how that gap has dramatically widened since 2000. When HHS wrote this rule, that VIP room basically contained all the health data that existed in the world.
Oh, wow, right?
Because the drafters never anticipated the smartphone revolution. They couldn't predict we'd be generating terabytes of our own medical data outside the hospital walls through, wearable tech and direct-to-consumer health services.
It's crazy. Well, let's look inside that VIP room. Let's look at the doctors, the nurses, and the insurers who are actually bound by this law. Because even inside the club, it's not a wall of silence. The operational heart of HIPAA isn't a mandate to lock everything in a vault. It's a standard called minimum necessary.
Yeah, it's a principle of proportionality. When a covered entity uses or shares your health information, they are legally required to limit it to the minimum amount necessary to accomplish their specific goal.
So like a billing clerk processing a claim for your broken arm needs to see the x-ray results and the orthopedic codes, but they do not need access to the clinical notes from your psychiatric history to process that claim.
Exactly. And that proportionality applies to the primary mechanism of data flow, which is known as TPO.
Right.
That stands for treatment, payment, and operations. Contrary to popular belief, HIPAA actually allows for the free-flowing sharing of your information for those three things without needing your signed authorization.
Wait, so if I'm in the hospital, the nurses can discuss my case at the nurses' station without me signing a form. Isn't that exactly what people are afraid of?
If we connect this to the bigger picture, you'll see why TPO exceptions are absolutely vital and how they actually function. Because modern hospitals use role-based access in their electronic health records. A nurse logs in, and the software only shows them the clinical data for the patients on their specific floor.
Okay, so the system restricts it automatically.
Right, the system restricts their view. If a doctor had to get written authorization from a patient every single time they needed to consult a radiologist or hand off care to an ICU nurse, which falls under treatment, the entire healthcare system would just collapse.
It would completely grind to a halt. And operations is the one that really surprises people. That covers things like quality assessment or training medical students.
Yeah.
A hospital can use your chart to review whether a surgical team followed safety protocols, all without asking your permission first, because that's considered a core operation of running a safe hospital.
Yeah, and that brings us to a crucial distinction. There is a vast difference between informed consent, which is a patient agreeing to undergo a medical procedure, and high-pay authorization.
Which people get mixed up all the time.
Constantly. High-pay authorization is you giving permission to disclose your data outside of that TPO circle, like if you want your records sent to a new employer or maybe a journalist.
And there are also specific times when privacy has to yield to a higher societal duty. The classic legal precedent here in the sources is the Tarasov case from 1976.
Oh, yeah, the duty to warn.
Exactly. Yeah. It established the duty to warn. If a mental health patient makes a credible threat against an identifiable third party, the clinician may, and in some jurisdictions, must breach confidentiality to warn that person. The duty to protect human life just completely overrides the duty to protect data.
Yeah, it is always a balancing act. You have data flowing freely for treatment, restricted by role-based software, and occasionally breached for public safety.
But if data is allowed to flow between hospital staff for treatment purposes, where do things go wrong? Because when you dive into the sources, the most common threats aren't shadowy hoodie-wearing hackers in distant countries. The biggest vulnerabilities are the people already inside the building.
Yeah, insider snooping. It is arguably the most pervasive threat in healthcare privacy.
The 2008 Farrah Fawcett case at UCLA Medical Center is the textbook example here. She was being treated for cancer, and an employee accessed her confidential medical records without any treatment reason, just pure curiosity or, perhaps looking for a payday, and leaked her diagnosis to the National Enquirer.
Which is just awful.
The tabloids knew she had cancer before she'd even told her own family.
Yeah, and UCLA ended up firing over a dozen employees for snooping in celebrity records. They actually had a similar issue with Britney Spears' records around that time.
Right.
The incident was so egregious it drove California to pass a much stricter state law, imposing fines of up to $250,000 for those kinds of violations.
But how does a hospital actually catch an employee doing that?
Hmm.
You mentioned role-based access earlier, but if an ER doctor decides to look up a celebrity who is admitted to the oncology ward, How do they know it was him?
Well, the HIPAA security rule mandates that covered entities maintain strict audit logs. So the computer system tracks exactly which user ID opened which patient file down to the exact second.
Oh, wow.
Yeah, every time you click on a chart, you leave a permanent digital footprint. So when a celebrity is admitted, compliance officers will run reports on that specific chart and cross-reference the user IDs against the actual care team. If you aren't on the care team, you get flagged.
Here's where it gets really interesting, especially for anyone listening who works in a clinical setting. It's not just the blatant selling to tabloid stuff that gets you fired. Around 2010 to 2012, there was this massive wave of nurses across the country getting fired for social media posts. And the wild part, none of them were using the patient's names.
Right, because they assumed they were operating safely within the law. A nurse might post on Facebook like, had a crazy shift, a 25-year-old guy came in with a bizarre leg injury after a motorcycle crash on Highway 9. They felt they were just venting or, seeking community after a hard day.
Yeah, but it becomes a dangerous game of guess who. You don't have to post a person's name for it to be a federal HIPAA violation. The standard is whether the person is reasonably identifiable.
Exactly.
If you provide enough contextual clues to the specific hospital unit, the rare condition, the timing of the accident, that patient becomes instantly identifiable to their family, their friends, or their coworkers who read the local news.
It exposes a massive gray area in human behavior because we tend to think anonymity is just the act of stripping away a formal name. In reality, anonymity is a complete illusion if the surrounding data points are unique enough.
And if it's that easy for one nurse to figure out who a patient is from a Facebook post with just a few context clues, how can hospitals possibly promise that the massive data sets they sell to researchers are actually anonymous?
Well, HIPAA attempts to solve this with something called the safe harbor method. The rule states that if a covered entity strips away 18 specific identifiers from a data set, things like names, exact dates of treatment, full zip codes, the data is legally considered de-identified. And at that point, IPA no longer applies and the data can be shared or sold freely.
But the sources highlight a piece of research from the 1990s that totally shatters that safe harbor logic. Which brings us back to LaTanya Sweeney, the computer scientist we mentioned. She wanted to test how anonymous this data really was, and she discovered that you only need 3 basic data points to uniquely identify roughly 87% of all Americans.
It's staggering.
All you need is a 5-digit zip code, a birth date, and sex.
And when you break down the mechanism of that math, it is both brilliant and terrifying. Because a typical zip code might have, say, 30,000 people. Roughly half are men. Now, how many of those 15,000 men were born on one specific day, like July 4th, 1960?
Right.
Maybe one. Suddenly, a massive pool of 30,000 people filters down to a single identifiable individual.
Which is exactly the stunt we mentioned at the start of the deep dive. In 1997, Massachusetts released gay-identified health records for state employees for researchers. Sweeney bought publicly available voter registration data, which included zip codes and birth dates. She cross-referenced the voter list with the anonymous health records using her 3 data points and successfully re-identified the medical records of Governor William Weld.
Yeah, and that demonstration fundamentally shaped the debates around the HIPAA safe harbor list, because it proved beyond a shadow of a doubt that anonymized is not the same thing as unlinkable.
If 87% of us can be pinpointed with just a zip code, a birthday, and a gender, it feels like.
Yeah.
I mean, if de-identification is that fragile, are these safe harbor rules essentially just a leaky bucket in the digital age?
This raises an important question about the future of medical research. De-identification reduces the risk, certainly, but it cannot entirely eliminate the risk of re-identification, especially today with machine learning and massive commercial data sets tracking our location and, our purchasing habits. The target on healthcare data is only getting bigger.
And when hackers hit that target, the fallout is staggering. Look at the Anthem breach in 2015. Hackers got into Anthem, which is one of the biggest health insurers in the U.S., and accessed 78.8 million records.
Millions, yeah.
Names, Social Security numbers, employment data. It remains the largest healthcare data breach in U.S. history.
And that breach is a perfect example of why the government had to update the law. In 2009, they passed the HITECH Act. It finally gave HIPAA financial teeth.
Because before that, the fines were basically just a slap on the wrist.
Exactly. Penalties were relatively small. But HITECH introduced tiered financial penalties for violations based on the level of negligence. Crucially, it made business associates directly liable for breaches, whereas before, only the hospitals bore the legal brunt.
Right, and because of those HI-Tech mechanisms, Anthem ended up paying a record-breaking $16 million settlement to HHS's Office for Civil Rights, the OCR, plus a $115 million class action payout to the victims. The financial risk of holding data finally started to match the privacy risk.
But we've spent this entire time exploring how this law penalizes people for sharing your data inappropriately. But there's a whole other paradigm to HIPAA that the public almost entirely ignores. HIPAA actively penalizes providers for withholding your data from you.
Oh yeah. The case that proves this shift is Signet Health in 2011. The government handed down its first ever civil monetary penalty for a HIPAA violation. And it was a massive $4.3 million fine. And it wasn't for a hack. It wasn't for an employee leaking a chart to a tabloid. It was because Signet Health denied 41 patients access to their own medical records.
Yeah, under HIPAA, patients have a fundamental legal right to obtain copies of their own medical records, usually within 30 days. And you have to ask why a doctor's office would refuse that.
Right.
It rarely comes from malice. Often it's a fear of malpractice suits or the sort of paternalism where a doctor thinks the patient won't understand the notes, or simply the administrative burden of using outdated software systems to compile a massive chart.
But the law doesn't care about administrative burden. Since 2019, the OCR has been running the Right of Access initiative. They are actively prosecuting providers who ignore or delay patients trying to get their own charts. Privacy law cuts both ways. It dictates don't leak my data to them, but it also demands give me my data.
Yeah, and while we are untangling these complexities, we should really tackle the rapid-fire misconceptions the sources highlight, because the public understanding of this law is just incredibly distorted. Let's start with a major one from recent years. Asking if I'm vaccinated violates HIPAA.
False. I mean, we saw this everywhere during the pandemic. HIPAA restricts what covered entities like your doctor can disclose. It does absolutely nothing to restrict a private business, an airline, or a restaurant host from asking you a question about your health. It reminds me of the scene in The Office where Michael Scott just shouts, "I declare bankruptcy," as if saying the words out loud magically invokes federal law.
Yes, exactly.
People shouting HIPAA violation at a restaurant bouncer doesn't make it real.
It really doesn't. And here's another pervasive myth. HIPAA means the hospital can't tell my family anything about my condition.
Also false.
Right. Providers are allowed to share relevant information with family involved in your care unless you explicitly object. And if you're incapacitated, they can use their professional judgment. When a family member gets stonewalled at a hospital desk, they're usually hitting an overly cautious institutional policy born out of fear of lawsuits, not the actual text of the HIPAA regulation.
It's also worth noting how isolated HIPAA is globally. International students often get confused by HIPAA because in Europe, they operate under the GDPR, which covers essentially all personal data controllers, regardless of industry. The European model focuses on the data itself. The American model focuses on who holds the data.
Yeah, and even here in the U.S., if you go to a student health clinic on a college campus, those medical records might not fall under HIPAA at all. They often fall under FERPA, the Educational Privacy Law.
Wow.
So HIPAA is uniquely, confusingly narrow.
So what does this all mean for you listening right now?
It means understanding that the boundary of patient privacy is easier to cross than ever before. We are having intimate medical conversations over video calls. Doctors are texting colleagues on their personal phones to consult on cases. We are constantly messaging through patient portals. The digital footprints are everywhere.
And for nurses and healthcare workers, this isn't some abstract regulatory debate. Here, violations are a leading cause of termination. Based on everything in the sources, those lines are almost never crossed out of cartoonish villainy. They are crossed through convenience, like texting a coworker a lab result on an unencrypted phone because it's faster, or through sheer human curiosity, like peeking at a neighbor's chart when they get admitted.
Yeah, and knowing exactly where that legal line sits is a vital career-protecting skill. You have to respect the audit log. The system is always watching. You leave a trail every time you look.
I want to leave you with a final thought to mull over. We've talked extensively about human curiosity and human error today, but consider where healthcare is going right now with the rapid integration of AI scribes in exam rooms. These are tools designed to listen to your appointment and instantly summarize the clinical notes. To do that accurately, an AI algorithm might be tasked with reading your entire medical history in milliseconds to prepare that summary. So how does a non-human entity comply with the minimum necessary standard? Does an AI have a curiosity problem, or does the tech company training the AI have one? If HIPAA is built as a bouncer for a VIP room of human doctors, what happens when the bouncer is an algorithm? It's a question to keep in the back of your mind the next time you see a microphone sitting on your doctor's desk. The vault has doors, and we're still figuring out who holds the keys.